First of all, I welcome everybody, and we are really happy to have you on board. This is the first international initiation video conference. So we are talking about the AXSANA study, and I'm very happy that you are very far in your countries. You have the ethical approval, we exchange the contracts, and you're really ready to go. We could start the trial in Germany with 80 patients in now, and we are very happy to have you on board now. Now, the AXSANA study is an acronym for Axillary Surgery After Neoadjuvant Treatment. And as you know, it's a prospective multicenter cohort study to evaluate different surgical methods of axillary staging. And as you know, there are different techniques that are used worldwide. Some perform central lymph node biopsy only. I know, especially in Italy, it's a technique that is widely used. In other countries, they do not accept the central node only technique. With regard to the Sentina study or the ACUSAC 1071 study that showed a higher false negative rates. And in many countries, surgeons say, no, the false negative rate is so high, so we do not translate it into, we do not use this as a regular measure. Others say, oh, it's okay for us, even if the false negative rate is a little bit higher. So there are new techniques like the targeted axillary resection or even the targeted lymph node biopsy alone. So this is the background. We have already gone through it a little bit. The optimal surgical staging is not known, especially for patients who convert from clinical node positive to clinical node negative under chemotherapy. And as you know, axillary resection has been the standard over decades, and in many countries, it is still used as a standard surgical procedures, but we do not have a standard worldwide. And in order to compare the outcome of different techniques, and as you know, we only have data on false negative rates, and we do not know at all how these false negative rates really translate into recurrences. So this is a very open issue. So does a higher false negative rate for the central lymph node procedure really translate into worse invasive disease-free survival or axillary? So we do not know this. And since we have a lot of open issues, we decided to have a simple register, put every procedure in this register, everything that is performed, and then look at outcome parameters, and we'll see the primary endpoints a little bit later. So it's a European prospective cohort study. Our aim is to accrue around 3,000 patients. And so far, 13 countries are participating. And you can see this very nice map where you see the status. You see the light green is Germany that is already recruiting. The dark green are countries that received the ethical approval. And today we have another dark green country, which is Spain. And I got the information 1 hour ago from Isabel Rubio. So the green countries are countries that are interested to participate and who submitted the protocol to their ethical committees. So what is very important for this study, it does not influence the choice of treatment. So we also do not need a patient assurance, because you just do what you do, and the study makes sense because we have so many different guidelines and so many different standards. We have 3 primary study aims. The first one is to evaluate the 5-year invasive disease-free survival for patients who convert from node positive to node negative. 4 patients treated with different axillary staging techniques, as we discussed before. Second primary endpoint is the evaluation of the 3-year axillary recurrence rate, and then we look at life quality and arm morbidity for patients treated with these different techniques. So we also have secondary study aims, and there are many, many secondary aims. Certainly the feasibility of different forms of axillary staging techniques, the detection rate of target axillary resection, central lymph node biopsy only, or target lymph node biopsy. the number of removed lymph nodes as a surrogate parameter for the surgical extent of the different techniques, the operating time as a surrogate parameter for surgical resources and costs. We look at factors, marking techniques associated with successful detection of the target lymph node, certainly the impact of training on success rates for targeted X-ray resection. And there are many more questions. For example, how do institutions decide for patients with a YCN0 but YPN plus status? And you may know that there are some institutions who do X-ray resection after chemotherapy when the central lymph node X-ray resection or targeted X-ray resection is positive. Others translate the data from the AMAROS trial into the neoadjuvant setting and would perform radiotherapy of the axilla. And we also want to assess the procedures and also the outcome. We want to assess factors contributing to a decreased quality of life and subjective symptoms of arm mobility and economic resources. So in the end, what we are looking for is oncologic safety, life quality, and costs. So these are the main outcome parameter. And I think within this large register, with all you participating in many countries in Europe, we will be able to answer many, many questions.
Okay, so who can participate in the AXSANA? Patients with invasive breast cancer that has been diagnosed by core biopsy, and these patients are non-metastatic. So distant metastasis, extramammary breast cancer, inflammatory breast cancer, or recurrent disease are exclusion criteria. Also, any patient who has history of invasive cancer of any kind, including breast cancer, of course, or DCIS, cannot participate in AXSANA. Since after the amendment, the fine needle aspiration or core biopsy of the lymph node is optional and not mandatory anymore. You can, of course, do this if it is according to your guidelines in your hospital and in your country. But if you decide to omit the minimal invasive biopsy, you can still recruit the patient and enroll them in AXSANA if you decide that the nodes are highly suspicious on imaging. So these patients can participate in AXSANA after the amendment. If you have decided to perform minimal invasive biopsy or fine needle aspiration and the result has been either negative or inconclusive, these patients can still participate in AXSANA if you decide together with your colleagues, for example in the tumor board, that the patient is CN+. So if you basically don't believe the result of the fine needle aspiration or core biopsy of the lymph node, and if you decide that your final classification is not positive, these patients are able to participate in AXSANA. Of course, patients need to be scheduled for neoadjuvant chemotherapy and need to be 18 years old. Any patient who has suspicion or confirmed supraclavicular or parasternal metastasis cannot participate in the trial. Lymph node marking, which is done in some countries and is necessary if you're planning to perform targeted axillary node biopsy, is optional. So if in your country the standard is to perform either sentinel node biopsy alone or axillary lymph node dissection, you don't have to mark the lymph node. Several documents each national steering committee has already received from the EU breast, and these documents will be provided to the study sites by the national steering committees. So in each country, the study sites will be managed by their national steering committee. These documents are, of course, the current version of the protocol, the patient information and the informed consent form in your local language, signature and delegation log, the subject in the identification log and the CRF, and also the quality of life questionnaires. Other documents such as ECRF login and password will be provided by EU breast directly. So the study sites will not receive these data from their national steering committee, but from us directly. And right now, the patients complete their quality of life questionnaires on paper, and these questionnaires need to be sent either via email or fax to national steering committees. But we hope that the online platform for patients will be open within the next 2 months. We are just testing this platform. And from then on, the study sites will receive an invitation for the patient. It's just one paper site, and they will print it for the patient, and the patient can log in on herself and complete the questionnaires by herself. So it will be easier for the study sites from then on. As I said before, each national steering committee is going to manage the study sites in their country. And the national steering committees have already received an Excel file that has been sent to them by EU Breast. And there you gather all the study sites that you have decided that will participate in the AXSANA study. And in this document, you assign to each study site a number. And this site ID is very important because it also is part of the patient ID later. And for example, in Italy, the code is IT. So the first study site, probably Milan, will be IT001, and the next study site in Italy will be IT002, and so on. So just check which country code you have been assigned, and this is how we build the site ID.
I would like to give important information to you about the patient registry for the AXSANA trial and how to deal with the documents that are sent to you by the National Steering Committee. At first, we would like to ask every study site to set up its own investigator binder where all the documents of the trial should be stored in. And it is important that also the signed informed consent forms of the patient that you would like to include into the AXSANA trial should be stored here. And you should also put in the subject identification log, which I will show you later on. On this subject ID log, you should register every patient you would like to include into the trial, and on this subject ID log, you will also have to create an individual patient ID. This patient ID consists of 3 parts as shown here. The first part are 2 letters that show where the country or where your study site is located. For Italy, for instance, it will be IT. The second part of this patient ID is your site ID. The site ID will be sent to you by your National Steering Committee with the study documents. And the third part is an ongoing number that you have to create at your study site yourself, meaning that the first patient you include will be 001, the second one 002, and so on. And if you have created this patient ID on your subject ID log, you can start the patient's registry into the trial via this ECRF documentation system. One document you will receive from the National Steering Committee is this signature and delegation log. And this log consists of 2 pages. Here is shown the first page. And on this page, you should register all the staff at your study site that is involved into the trial, and everyone should be given a function and should sign here, and also your local PI has to sign. And if it's completed, then you should scan this document and send this to your National Steering Committee. The second page of this signature and delegation log should be filled electronically, and here you should list all the persons at your study site that have or that need an access to the ECRF documentation system of the AXSANA trial. And you should fill in here the names and the email address. And this second page of the signature ID log should be sent to your National Steering Committee via email, because all persons that are listed here will get an email with the access data to the ECRF system, and also with a user manual with detailed descriptions about how to use the ECRF. This is also a document that is sent to you by your National Steering Committee. As I mentioned before, in this subject ID log, you should, or via this log, you should register all the patients that you include at your site into the AXSANA trial, and here you have to create the patient ID. This subject ID log is only for your internal use. You should not send this to your steering committee or to UBREST, but you should store it in your study binder. Now, what is the perfect time to include patients into the AXSANA trial? Well, the perfect time point would be before starting neoadjuvant chemotherapy, because all the data you need for inclusion are available at this time point. But if you have patients that are already undergoing chemotherapy, or that have completed it but did not yet undergo surgery, you can also include them until the day before surgery, if all the data you need for inclusion are still available. It is not possible to include patients after surgery, because the first quality of life questionnaire has to be completed by the patient within 4 weeks before surgery. The registry of the patients for the trial is only possible via the ECRF system, which is a REDCap database. You will also get a PDF file of all the CRFs, and you can use these PDF documents for your internal documentation, but they are not suitable for recruiting and documentation for the AXSANA trial. Therefore, you should use the REDCap system, and the login data will be sent to the persons registered on the second page of the signature and delegation log as shown before. And after logging in, you will see this dashboard where all the patients that were already included into the AXSANA trial at your site are listed, and you can see all the CRF files that are already created for these patients. And the status of the single CRF files is shown by different colors, which means red CRF files are the uncompleted ones, meaning that you started documenting within the file, but you did not yet complete your documentation. If you did complete one CRF form, then you have to change the status of this CRF form to complete, and the color will change to green. The green CRF forms will be monitored, and if the monitor creates a query because of inconclusive data, then he will change, or she will change, the status of the CRF form to unverified, which will be the yellow button. If the monitoring process is completed and all the data are judged to be correct, then the monitor will log the CRF form, which is shown by this small log sign under the completed CRF. Yeah, in case of queries, if you see the yellow button, then you should reopen this CRF form, and you should look inside the CRF for such yellow speech bubble. You should click here on this speech bubble, and then the query that was created by the monitor will open, and you can read it and check the data and correct the data. You should reply or respond to the query, and you can also comment on it. It is important that if you replied, that you should not change the status of the CRF form. It should remain unverified, because the monitor will check your response again and the data again, and if everything is fine, then the monitor will change the status of the CRF to complete, and he will or she will also log the form.
We have already registered more than 80 patients in Germany, so we were able to gather some first experiences with the CRF and eCRF, and I would like to show you quickly all CRF pages, all the documentation, and tell you which mistakes are quite common, or at which point there have been some misunderstandings. So the first part of CRF is the baseline. These are the basic data that you usually gather in clinical trials, and of course here we check inclusion and exclusion criteria. Then the most important part, the pre-therapeutic nodal stage of the patient, where you can document how many suspicious nodes you have seen, how large they were, and so on. And as you can see, there is a question, what is the final classification of the patient? This is very important, mostly because we have allowed patients with a negative or inconclusive biopsy result, or even without a lymph node biopsy, to participate in AXSANA. So it is very important that you classify the patient after the biopsy, if you've performed any, as either CN0 or CN+. And of course, only patients that you classify as CN+ are allowed to participate in AXSANA. The marking of the target lymph node is optional, as I said before, because some countries do not perform targeted axillary dissection. So in this case, you just document no. If you decide to perform a marking of the lymph node that you have biopsied before, we will ask you if the pathology or cytology report has been available before inserting the marking. The background for this question is that there are two strategies that the hospitals follow right now. Some doctors decide to insert the marker immediately after the biopsy. So they don't have the pathology report available, obviously, at that time, but it's nice for the patient because it's just one procedure. And others decide to insert the marker after they have received the final pathology or cytology report. And we don't really know which one is better, so this is why we ask this in the AXSANA trial. If you decide to insert a marker into the lymph nodes, it is very, very important that the study sites are as specific as it goes here, because we will be very interested to evaluate which marker has the highest detection rate and which ones are best visible on ultrasound, for example, in the case of clips and coils. And it is not enough to just document, for example, TuMark, because TuMark is just the manufacturer, but there are TuMark Vision, TuMark Professional, and so on. And the same with, for example, Hydromark, also a popular clip type, because there are different shapes of Hydromark markers, like butterfly or barrel. So here, if it is possible, if you know this, please document as specific as possible. The second part of the CRF is going to be completed before surgery, after completion of neoadjuvant chemotherapy. And there is a small reminder if the patient has completed already the health quality of life questionnaires, because the time slot to do this at baseline is within 4 weeks before surgery. So not too early, not at the start of the neoadjuvant chemotherapy, but not after the surgery. And this is why we have this small reminder here. We also ask you which surgical strategy you decided to follow with this individual patient, and most study sites that have recruited so far choose either axillary lymph node dissection or targeted axillary dissection or sentinel node biopsy alone. But if your strategy that you follow is not listed here among these options, just choose other and tell us in the free text which strategy you follow. The next part of the CRF is going to be completed after surgery, and our experience so far is that it is easiest if you do this immediately after the surgery, because you have all the data and you remember everything best. One of the questions here is the time duration of the surgery, and we really want to know the whole duration of the whole surgery. So between incision and skin closure, some study sites asked if we would like to know the duration of the axillary part of the surgery, but we don't want you to measure anything that you wouldn't measure outside of the trial, and we want to keep it simple. So we are really interested in the whole duration, and we will try to evaluate and compare different surgical techniques and see which one takes most time. And for this analysis, we will of course exclude patients with reconstructive surgery and with bilateral surgery. So this is why we also ask if the patient received any reconstruction or contralateral surgery at the same time within one procedure. There have been some misunderstandings concerning marking and localization techniques. In the AXSANA, we have the definition that the marking is something you do before neoadjuvant chemotherapy. So basically inserting a marker, any type of marker, clip, coil, magnetic seed, ink, we refer to as marking of the lymph node. The localization is any procedure you perform to search specifically for the marker that you have inserted. And here you see many different options, and this is because we are recruiting in different countries, and some study sites so far in Germany were a little bit confused because they don't even know that there are some localization and marking techniques available. For example, some countries mark the lymph nodes with a radioactive seed, which is a technique unheard of in Germany and not popular here, but this is why we have so many options. If you decide to mark the lymph node before neoadjuvant chemotherapy, but to omit the localization before surgery, you will be asked why this was the case. And this is very important because in the publications so far, usually we don't even know why in some patients the target lymph node has not been removed. Was it because it was never planned? Is it because it was not necessary because there was an intraoperative localization, or was the marker not visible, which is of course a very important criterion we would like to evaluate. So this is why there is this one specific question here. Then we also ask if there was a specific intraoperative localization step, which might be, for example, intraoperative ultrasound if you have marked your lymph node with a clip or a coil. If you have used ink as a marker, you will of course look for the ink and perform ink visualization during the surgery. If you're using magnetic seeds, you will be looking with a magnetic probe for your magnetic seed. Some study sites so far are using a strategy where they mark the lymph node with a clip or a coil before neoadjuvant chemotherapy, but they do not perform any specific preoperative or intraoperative localization technique. They perform sentinel node biopsy and they send the sentinel lymph node to the radiographer to check if the clip is inside or not. So in this case, there has been no preoperative localization step and no intraoperative localization, but as we know, in 3/4 of the cases, the clip will be in the sentinel node. In this case, if you're using this strategy, do not choose gamma probe here, because gamma probe is not used in this case, in this example, to specifically search for the target lymph node, but to search for the sentinel lymph node. The option gamma probe is only for the study sites that use radioactive seeds to mark the lymph nodes. And here I brought you an example from one of our study sites that has already started recruitment. This is a very popular technique in Germany. So the clip has been inserted into the lymph node before neoadjuvant chemotherapy. After the chemotherapy, before surgery, the colleagues looked for the clip with ultrasound and they inserted a wire into the clipped area. So in this case, we can complete the CRF responding yes to the question whether the preoperative localization has been performed. Then wire was the technique that has been chosen, guided by ultrasound, and there is also a question whether the localization was successful or questionable. We all know that some or most of the clips and coils are not always visible on ultrasound, so we know that sometimes if the clip is not visualized perfectly, but we see something that might be the clip, we will insert the wire. And in this case, the TLN, or the localization of the TLN of the target lymph node, is questionable. The second question, intraoperative localization, can be answered with a no in our example, because the colleagues performed no other specific search for the target lymph node. They haven't used intraoperative ultrasound. They have just removed the part of the tissue that has been marked with a wire before surgery. Then this part will be completed after you have received the final histology report from your pathologist. And as you can see, there is a table where we can insert the numbers of lymph nodes. And this table can be completed only if you send the lymph nodes in separate vials. Of course, you don't have to send one lymph node in one vial, but you still have to send them to your pathologist grouped. And here I also brought you a small example. This is a study patient who had a clip inserted into the target lymph node before start of neoadjuvant chemotherapy. The surgeon planned targeted axillary dissection, which means that the target lymph node should be removed and the sentinel node biopsy will be performed at the same time. There were 2 sentinel lymph nodes removed, and one of them had the clip. So this was the lymph node that is target lymph node and sentinel lymph node at the same time. This is our first vial that goes to the pathologist. This lymph node was metastatic. The second sentinel lymph node doesn't have the clip, obviously, so this is just the sentinel lymph node. It's not a TLN. This is our second vial that goes to the pathologist, and then the surgeon removed 2 other additional lymph nodes because they were suspicious on palpation, and these 2 lymph nodes go in the third vial to the pathologist, and these lymph nodes were tumor-free. And it will be great if you speak with your pathologist and inform him about the ongoing AXSANA trial, because he will receive several vials, something which probably he's not used to. And it's very important that he mentioned the vials separately in his pathology report, because otherwise you will not be able to complete the table. So we're back to our example. As you can see, the first question is, has there been a lymph node that is at the same time target lymph node and sentinel lymph node? The answer is yes, there was one lymph node that was both, and it had a macrometastasis. Then we have a sentinel lymph node that is not target lymph node, and it was a tumor-free node. And then we have removed 2 additional lymph nodes that were tumor-free. And we all know that sometimes during targeted axillary dissection, we will remove some additional lymph nodes because we are searching for the target node, and you can document such non-target lymph nodes also here under further notes. And this is the last part of the CRF before the patient goes into the follow-up. And here we will ask you about early complications of the surgery and also the planned therapy. And obviously the most important part regarding therapy that you will recommend and the patient will receive is the radiation therapy, because we would like to compare different surgical staging techniques, but we would also evaluate different local regional therapies that the patient will receive. This is the first CRF that will be completed after year 1. You can either invite your patient to come to the study site, you can call your patient and discuss this on the phone, or you can call the doctor from the primary care who is checking regularly on your patient. It depends on the standard in your country, and it is of course up to you how you will follow up your patients. Here at year 1, you will be asked about the therapy that the patient has received, and of course, the basic follow-up data regarding the oncological outcome will be gathered. The follow-up after year 2, 3, 4, and 5 is more simple because, of course, we already know which adjuvant therapy the patient received, and we will not ask about it later. A very important part of the evaluation will be the quality of life. This part of the analysis will be performed by our colleagues from the Karolinska Institute in Stockholm. And the quality of life will be assessed using 4 standardized questionnaires. And in addition, there are some questions regarding smoking habits and training habits. Right now, the online platform for quality of life questionnaires is being tested. So right now the patient needs to complete the questionnaires in printed form and then give it back at the study site, and the study site will send these questionnaires to the National Steering Committee. But I hope that within 2 months we will be able to give you access to the quality of life online platform so that the patient can complete everything online without the study sites having to gather the questionnaires. And in case you have any questions, you can contact one of us, Thorsten Kühn, Steffi Hartmann, or myself. And well, this is the end of the presentation, and I'm very happy to answer your questions.
Thank you very much for this excellent presentation, and Steffi also. I want to stress one very important issue, and I would ask you to pay special attention to the adjuvant radiotherapy, because we have learned recently that the adjuvant radiation treatment strategy are quite different. And I learned that in some countries, even after a negative target X-ray resection or a negative central lymph node biopsy, or even a negative X-ray resection for patients who convert from N+ to N-, there are some countries who perform X-ray radiotherapy for these patients. So I think it will be very, very important to have a very accurate documentation of the adjuvant radiotherapeutic strategy. I think this is very important. Okay, this was my comment, but do you have questions? This is very important.
We have nothing in the chat, but Michalis is raising his hand.
Full of questions. First of all, I just want to make sure that I got it right. The date of consent should be the latest 4 weeks before surgery.
No, the date of consent might be 1 day before surgery, but it can't be after the surgery. If you give the quality of life questionnaires to your patient 1 day before surgery and she completes it and gives it back and signs the informed consent, it's okay.
Sorry, I remember you saying something about 4 weeks before surgery.
This is the time slot to complete the baseline quality of life questionnaires. So you shouldn't give them to the patients too early during neoadjuvant chemotherapy or before neoadjuvant chemotherapy, because this would be too early. We have decided that the time slot will be 4 weeks. So it might be 1 week before surgery, it might be 1 day before surgery, or 4 weeks before surgery.
Between 4 weeks and 1 day before surgery.
Yes.
So. Okay.
Rosa, you have a question? Oh, sorry.
Oh my God. I have 2 questions. The first one is, if I see the study flowchart, I have understood that patients who remains node positive after surgery are not interesting for the purpose of the study. Is that correct? Is the follow-up stopping after surgery?
No, all patients who convert to clinically negative node status stay in the study. And these are the patients who are very interesting for us, all patients who converted to clinically negative node status, because these are the patients where you can perform sentinel node biopsy or axillary dissection or the targeted axillary dissection. If a patient
if they remains YPN plus, they are also interesting.
They are still in the study, yes. If a patient has clinically suspicious nodes after the surgery and after, after the neoadjuvant chemotherapy, they will be still documented in the study, but this is not the group that is the main focus of AXSANA. This is true. Torsten, would you like to comment on this?
Yeah, it's not the main focus, but we will be able to provide very important additional data because, as I pointed out before, treatment strategies, even for patients who are YCN0 but YPN+, there are different treatment strategies. Some perform radiotherapy to the axilla and some do axial resection. We would like to assess this, and this would give us the unique possibility to assess these different techniques. Another issue will be interesting to collect data on patients for micrometastasis, because there are very, very few data on micrometastasis, and we can assess how different which strategies there are. And I know in Italy you have the trial, the NeoNOT2 trial, which will be interested, and we already discussed if we could have a joint venture on this. So there are many more issues that we can solve with this database.
Okay, and the other question is about the surgical time. If you only distinguish between breast conservation and mastectomy, don't you think that in cases of oncoplastic procedure, the time for breast conservation is a little bit affected by this? Do you want us to sign as reconstruction the oncoplastic procedures?
We have discussed this, and it's quite hard to say which oncoplastic surgery is really the long one and the complicated one, and which one is like a, let's say, small mastopexy, for example. So we decided to define reconstructive surgery as using an implant or a flap, and we will evaluate all patients undergoing breast conserving surgery as one group, because probably they will be receiving different axillary staging techniques independently of the use of the oncoplastic surgery. But this is a good point. Still, we will evaluate them as one group.
Okay, that's all for me. Thank you.
Michalis, I think you wanted to ask something before.
Is there a way to get to know REDCap a bit more? Is there a demo version or a training version of REDCap? This is my first question. And the second one is, do we do questionnaires on years 2, 3, 4, and 5, etc.?
Well, the first question, REDCap, is actually very, very simple, very intuitive, but we have a user manual that we have written for the study sites that I will send to you. It's a PDF file, and it's actually quite a good guide to REDCap for someone who doesn't know the platform. So each of the steps that we have been talking right now about are explained in the user manual that you will be receiving. And the second question, you mean the quality of life questionnaires, right? Yes.
Yes.
They will be completed by the patients first at baseline before surgery, and then at year 1, 3, and 5. So for this, as soon as the online platform is working, the study site will have to print an access data sheet for the patient and give it to the patient. And there is already a QR scan code if the patient has a smartphone, and also the link that she can copy into the browser and the password.
And it is exactly the same questionnaires. They don't change by the year.
They do not change. No, we decided to have just one questionnaire because it's easiest.
Okay. Okay.
Okay, are there any more questions? And maybe just to remind you, as Maggie said, you can start right away identifying patients who can be recruited for the AXSANA trial. Just look at patients who are under chemotherapy, because you can sign the informed consent can sign just within 4 weeks before surgery. So patients, usually you will, in the future, you will sign the informed consent at the time of diagnosis, probably because it makes it much easier to collect data. But in the meantime, now as you're starting, you can look at all your patients under chemotherapy who fulfill the inclusion criteria. And just before surgery, you can let them sign the informed consent.
May I ask, Michalis, which is your preferred strategy in Greece right now? Is it targeted axillary dissection, or which one is it?
It depends on the hospital. There's no uniform strategy towards it. There are some hospitals that do clearance, and some other hospitals that do targeted. Many hospitals change the approach by the patient. So for some patients, they will do axillary clearance. For some patients, they will do something less. There's no uniform approach for this at the moment. I have to say, though, that targeted is becoming quickly, very quickly, the preferable approach.
And in this case, which kind of marker is the most popular one?
It is mainly ink, so carbon ink. Mm-hmm. And one of the participating hospitals is quite good at this. They have published heavily on it. The other hospital is using the clip, just a metal clip, and they're putting a guide wire in the node just before surgery. In my hospital, we haven't done it. We have used the magnetic clip, but in limited cases because of the cost. In the other cases, we do SNBs.
Okay.
Mm-hmm. So, and we are interested in all techniques. So we have a little bit of the problem in Germany that TID is so popular that we are a little bit afraid of being flooded by TIDs. So we are very happy to include institutions who do a classical axillary section or central lymph node biopsy only.
Rosa, how is it in Italy? What is your preferred strategy?
We usually perform sentinel node biopsy. Professor Kuhn knows this, so we haven't started with TAD yet, either for any kind of marking. So for time being, this is the unique strategy.
And Rosa,
that's great.
Do you perform sentinel lymph node biopsy with at least 2 sentinel lymph nodes, or do you accept 1 sentinel lymph node? I read a nice paper from Viviana Galimberti recently, and she doesn't care for the number of sentinel lymph nodes, and she data.
We usually remove at least 2 sentinel nodes. It's very rare that we remove 1 sentinel node when we know that the patient had been not positive before. So it's more or less 2 the mean numbers.
The mean number, yeah, mean number, yes. But you accept if you find only 1 node, you are happy with that?
It happens. It happens. If we find only 1,
and you accept.
Want to look for other non-sentinel node to remove.
Yeah. Okay, very fine. So we are very happy having these data.
Let's see what happens.
We thank you, all the discussant, but also all your staff members who support these trials. And I think it's a unique chance also for you, Breast, for supporting our idea of European collaboration. I think this is a perfect example. So thank you very, very much.
Bye-bye.
Bye-bye. Have a nice evening. Bye-bye.
Bye.
Bye.
Bye-bye.